we will get started here. Where's my click? Okay. Well, let's actually start at the beginning. How about we do that? Let's go back to the top. All right, there's a better place to start. Okay. So this is covering the palliative care, comfort at end of life content. Yes, there's a lot of reading, and the different resources kind of discuss things in a little bit different way. Um, I like how the ebook um, brings together hospice and palliative care in a really understandable way, and also really discusses a lot of these different concepts in more of a linear way, I thought. But so what I did is I've taken some of the PowerPoint slides from the Gideon book and some of them um, from the Iggy book, and then some of them I have pulled from what we used in our old curriculum, just because they have the slides have good information on them that will relate to what comes out of the McKinney book. Okay, so we'll get started here. So in class, we will be doing activities. We'll be watching some videos and having, if we have time, we'll have a little discussion of some different things. So this will be covering all of my lecture, and I'll be, like I said, I'll be pulling things from all of the readings that you were assigned. So here's our learning outcomes, and yep, we have a lot of them. There's kind of a lot that goes on in this end of life. So we really want to look at that collaborative care. What does that palliative team look like? What does that hospice team look like? We want to make sure that we're incorporating the patient's culture and spiritual beliefs. Identify the need for providing psychosocial support to the family and even to other caregivers during the dying process, because we all will experience things a little bit differently, and I think you're getting some of that out of what you're reading in your final gifts. Identify clinical manifestations of end of life. Apply concepts of death and dying as they relate to the pediatric patient. Identify the nursing role in palliative care, and define ethics and the role of ethics in the end of life decision making. So we got lots of stuff to cover here. So palliative care. So we're starting off with the information from the Giddens book, and I'm also pulling things from the ebook here. So here's the definition of palliative care. And as you look through that and you think of that, you think, well, doesn't seem to be that different from hospice, and we'll talk a little bit about that in a little while when I'm comparing them. But basically, palliative care came about because hospice care had very specific parameters. To be able to be covered for reimbursement, you had to fit into these parameters. And also, people need special care long before they met the terms to fit into hospice care. And so palliative care kind of came about basically out of reimbursement, a need for care that doesn't fit into hospice. And I'll say it again as we move on, is that a lot of people, by the time they got into hospice care, really had much less than the 6 months to go, and so there were so many things that could have, so many not treatments, but so much care could have been given prior to that would have made their quality of life better, and got them on the path for having a good death sooner. All right, so goals in palliative care. So again, this is similar to hospice, but starts earlier and is used with chronic illness. So what's on the slide should be self-explanatory, and just knowing that palliative care really comes about for those people who have chronic conditions. Well, if I go backwards, or do I have two of these slides? I do. All right. We can delete that slide. That's odd. Let me click up here. Nope, it must have gone backwards. Okay. Here's our goals. Palliative care. Here we go. Go back to here. Okay, so related terms. So there's usually a palliative care team. So there's nurses, there's primary care, there's specialty services, there's nurses and doctors who have specialties, social services, spiritual care, and ancillary services, speech and occupational therapy. We'll talk more about those later. But I just wanted you to know that like within the palliative care team or the hospice care team, there's all these other people. And because of that, there's a lot of terms that are used in different for different team members may use these different terms to define what they are doing or to define their role in palliative care. All right, so the impact of chronic disease, and this is really an important concept to understand. It'll help you understand your role when you understand where we are with chronic disease, and when you start to understand trajectory, you'll understand your role as a nurse in end of life. And so, the impact of chronic disease. So, um, um, people don't just die instantly or quickly like they used to in the past. So before we had good medical care, before we've made lots of medical advances, people would die from infection um, or an illness or an infection um, really quickly. But now we have these people who are on these chronic trajectories, and um, their their care kind of needs to be thought of early on to make sure that their quality of life from the point of diagnosis to the time that they die is still good. And in that process of their quality of life is also looking at where do we stop looking for a cure and where do we move into just providing comfort and support. So here's I'm talking about disease trajectory, and you know what? I'm gonna go back and I'm gonna say one more thing about this. So the aging, and I want to. This is my notes that I had here more than just what I wanted to say. The aging of the baby boomers is increasing our chronic disease again because we have our medical advances. So there's an increase in chronic disease that will need for an increase of palliative care and palliative care nurses. People, and like I said, people used to die quickly from disease and infection, but now they're living longer in this chronic state. So just really kind of keep that in mind, that this chronic state is not necessarily a curative state, because I think that's where a lot of our explanation with our clients when we're talking about trajectory is really understanding where that chronic state continues but the curative state ends. Okay, disease trajectory. This was talked a lot. A really good explanation was given about this in the ebook. In the ebook, their first square was actually on sudden death. And as you know, the disease trajectory on that's pretty evident, where you're pretty much going along and you're good, and then boom, you're dead. And so you can see how when we're looking at trajectories and we're looking at how we're going to use that in our role as nurses, you see why these three are probably the more important, because these are the patients that we're going to see over a long period of time. So to be an advocate for our patients, we need to understand disease. We need to understand the disease trajectory. We won't be giving the diagnosis or the bad news to the patient, but it is in our role to explain what happens next. We are going to be the ones who get asked the questions. So, how long do you think I have to live? Or what's going to happen to me next? And what is the treatment going to be like? And so we need to understand these trajectories so that we can give them open and honest communication and information. We also need to be skilled in assessing how much information is needed and or how much is too much. So, day one, talking to a client about what the very end will look like isn't necessary. Um, and in cases where you're a palliative care nurse or you're a hospice nurse, you're going to form a relationship with this client, and you're going to have a lot of time to work with them. Um, in the hospital setting, you may see them for that week that they're there, and you might not see them again. But that doesn't mean that you're not part of this. So if you're seeing a client in the hospital who is down in this area, or has been in and out of the hospital a lot, and every time they come in they're a little worse and they go home a little worse, so they're not bringing they're not recovering back up to that higher level. You can explain to them each time, this is what's happening now, this is what the future could look like for you. And so it is important that we continue to ask them what they understand about their trajectory, what they understand about their disease process, and what thoughts that they've had about end of life. Let's see. And so what this one is showing is, here's the cancer, which in general, they say that people mostly do, through treatment, are doing pretty good or functioning pretty good. I mean, they have their ups and downs related to their treatment, but then they kind of come to a point where treatment isn't working anymore, and they kind of fall off kind of quickly, um, and into death. And then this one, whoops, that's why. Okay, I'm going to go to this so that doesn't happen. Okay. And so you can see here with this is like an organ failure level here, where um, because of their organ failure, and they have mostly frailty or dementia, but um, I'm going to use that for the next one. But so organ failure here, where they have their illness, they have a down, they kind of come up, so they might be hospitalized here, they come out, they do okay, but then they sort of have this slow decrease in their ability to recover, and it's kind of a slow, prolonged death. And then this last one, in the ebook, this says frailty instead of up here, but they had frailty where they do okay, and then they have something, they get ill, they end up in the hospital, and they can kind of recover, but they don't recover quite as much, okay, and they don't recover quite as much. So they have some times where they're going to be hospitalized due to um, illnesses and problems and possibly treatments. And so these are the clients that you're going to interact with a lot, who are going to possibly need continual education on their trajectory, and so that they can keep their end of life uh, options open, and that we can make sure that they move into hospice care or an increase in their palliative care as they move along. A paradigm shift. So part of the shift is to evaluate early the lack of cure, and so I'm talking about curative state, but to a lack of cure, so that palliative care can be initiated early. Um, and again, we've been on a trajectory, and medicine is very different from nursing in this sense, is that medicine is very much um, their goal is to cure, their goal is to save lives, and so it's very difficult for them to let go of that goal. And so our shift is wanting to make sure that earlier on we have an understanding that the trajectory as of right now is that their disease process will go this direction, and then they will die. And so we want to make sure that what we are doing for them is providing quality of life, is helping them with quality of life. Um, because oftentimes we can treat and treat and treat and treat and treat, um, even, try to cure, try to cure, try to cure, but in the process we shorten their quality of life. And even sometimes quantity of life. So that's kind of where this paradigm shift is. Here's just a nice graphic of talking about the interprofessional teams, and I already mentioned that how we have nursing and social services, and we have physicians, and we also have specialty nurses and specialty physicians, and spiritual care and ancillary care, which would be like physical therapy and occupational therapy, and for children that might be developmental therapy and play therapy and different things like that. So just knowing that this is this like so many things now in healthcare is defined by its collaborative care. End of life care is not done in a vacuum. It is not done with just a physician, just an oncologist, or just a primary care, or just a cardiologist. It has to be now a team, a diverse team of professionals to walk this patient through this disease process in the best way possible. And then here's just a picture, this comes out of Giddens, of interrelated concepts. So again, when we're looking at things with concepts, when we're teaching through concept, we want you to understand all the other concepts that kind of work around palliative care. In this bubble, we could even put hospice care in there. It's as far as all of these other things are still going to be related to it. Okay, so death and dying. So now we're going to move more into the Iggy book. So some of this information comes from Iggy, but I've also been taking points and comments out of the ebook to fall into these too. So one thing is, and I know this has probably come up in a lot of your with your readings and stuff, is really wrapping your brain around the fact that everyone will die. Eventually, we are all dying. We are all yeah, we're all on a path to at some point for our lives to end. And so by knowing that and embracing that as providers, as professionals, we can help our clients also embrace that. And we have a great opportunity to affect the dying process for people, because and you know, you've heard that, you know, there's like you know, 10 of us to every one individual in the country, or some huge number like that. I mean, there's just tons of nurses, and we have the ability, because of the amount of time that we spend with our clients and the amount of interactions that we have, to change and to assist them to change a poor dying process into a better dying process, and to assist them in having their needs met. And I want you guys to really keep in mind how similar this is to the birth process. And it's very easy to allow yourself to think, I don't know how anybody could spend their lives helping people die, because that would just be so depressing and morbid. But there's just as much value to that person as there is to a person who wants to have a birth a certain way. You just don't get the thank yous from them after the process because they're gone. But people want to die in a certain way. They want to have some control of that. And so by being there and listening to them and supporting them, you are giving them so much, and not allowing yourself to be so sad, because dying is inevitable. I mean, it will happen. You just have the honor of being present with that person during that process. And it might be very emotionally hard for you, but I want you to walk away with that understanding that you've done something really great and really special for that person, and not walk away with I just was there when someone died. Rather that you were there with somebody when they probably needed you the most, maybe, and that you had the opportunity to guide somebody out of this life. And so I think that I think that those are are important concepts to remember as you move into this, so that you don't get as caught up on the morbidity of it that as a society that we struggle with. Um, so good death and bad death, and people want a good death. Um, and from the audio, the podcasts, and the different things that I posted, people want a good death, but they really don't know what that means. They think they know what that means, and then they don't understand that all of these other things that can be done to them will lead them down a path to a not good death. And so it's important to make sure that people understand what each treatment means, what it is, what the trajectory of that treatment is. Is that going to be a positive or a negative end for that client? And so, yeah, these are all important things to be thinking about, because we know, we have read, we have heard, people want a good death. People don't really want to think about it, so they don't really know what that means to them. Let's see. So when we're looking at most common cause of death, so heart disease, and then followed by cancer. So we have a chronic illness um, followed by a terminal illness. And so those are things to kind of keep in mind. And then when it talks about cultural awareness is important. And it's important to know this, because a lot of time, depending on cultures, um, their culture determines who is told about the prognosis, about the diagnosis, um, who shouldn't know, who knows. And so there's some ethical issues in that too. So it's important to understand that it also will help you understand how hope and faith kind of play out in their culture, because both of those have have an important role in um, in the end of life process. So some of this information, well, actually, all of this information should not be new to you. You should understand these. This should have come up in first year. But one of the things that I'm going to talk about with these is that the family needs to be involved, and open and clear conversation information needs to be given. Explain what you know about CPR and their survival rates. And some of this comes out of your reading and out of the podcasts and stuff, is that uh, CPR isn't like what people see on TV, and so they think that, oh yeah, I want CPR because then I'm going to come back to life, and then in a few days I'm going to be golfing again. But that's not really what it is. So generally, once you're over 50 years old, your ability to survive after CPR, even CPR done in the hospital, is quite uh, decreased. And I mean, you'll survive, but you're going to have deficits in certain things. And so survival and good survival, so quality of life after CPR initiated outside of the hospital, just really decreases those uh, quality of life things if you do survive it. And then if you have any kind of illness, chronic illness, um, anything like that, is going to deeply decrease that survival rate from CPR. CPR causes a lot of damage, and can be extremely painful for family members to watch. And so those are the open open and honest conversation information that people need to have when it comes to signing a DNR. And in my experience, that those explanations aren't necessarily done clearly, and what people think they know about CPR or intubation or any of those things is very different than what it truly is. Let's see. So again, part of us, when we're helping people plan for the end of life, we're also really having to understand what the trajectory of their illness is, and help them. Like if you have lung cancer or you have COPD, and uh, um, if you choose to be intubated, the chances of you coming off of intubation and being, functioning normally is very, very small. So, do you want to be put on a mechanical ventilation and then have to have your family make the decision to take you off? Or would you rather just not be put on it and then keep your family from having to make that decision? So there's those types of conversations that need to take place so that family understands what's happening. And this is just a example of a durable power of attorney. So let families know that changes can be made, things can be added and taken away. Remind the family about good death and what that looks like for the patient. So, what's good before you even kind of get into these conversations, if this hasn't been done yet, if one of these haven't been put together or DNR has not been put together, any of that stuff, it's to talk to the patient with family present on what does a good death look like to you, and so the family is aware that maybe for this patient a good death isn't being connected to all these tubes. A good death is being at home, um, and so it's making sure that that discussion is open before this even gets filled out, so that people uh, who are being named on this know what they're up for. They know what their role is. They know what's being expected of them. Okay, so make sure patient and family understand that DNR doesn't mean that the client is left alone to die. And I've heard that before, that people will say, well, I don't want to be a DNR because I don't want people to go, oh, they're dying, and everybody walk out of the room. Like, oh, we're going to throw our hands up. So let them know um, that support will be given and that nurses will be there providing care and comfort to the patient. That just because they choose to be a DNR does not mean that they're like left on the side of the road kind of feeling, but that there's people who will still be there providing care. Okay, so now we're going to talk a little bit more about hospice and palliative care. So there's two major differences, and it's all about timeline. This came about because of Medicare and Medicaid payments, or that should be, instead of payments, that should be reimbursement. Therefore, they function differently in the healthcare system. Starting palliative care at the beginning of the trajectory is the best. It is difficult for providers to give 6-month diagnosis. Often by the time the patient gets into hospice, they can have much less than 6 months. Oftentimes a few days to a week. So, so hospice or palliative care came around because reimbursement didn't occur unless the provider could say they had 6 months or less, and absolutely no curative treatments were going to be used. But there's a lot of chronic illnesses that that the basically like the palliative care would come up looking like a curative treatment, although it's not. It's just part of the palliative care, the comfort care. And so it couldn't be covered by hospice. And obviously, with a chronic illness, it can go on for much, much longer than 6 months. So there was like this whole group of people who really needed care, who really needed specific focused care, but couldn't get any, but couldn't really get it, and couldn't get it reimbursed. And so that's kind of where palliative care came into place. And palliative care isn't always 100% reimbursed. It's still working. There's still a process in that right now. Let's see. And that's another thing about the difference with, or the transition between palliative and hospice care is that because there's these parameters for hospice care, people didn't get into hospice until, close to the last few days or the last few weeks of their life, where now there's just much smoother transition for people who, even like cancer patients who are in palliative care, who they can just get to a point where they can say, you know what, I think that the treatment now is worse than the disease process. So my quality of life is really decreased. So I'm going to stop whatever it was, those treatments that slowed the tumor growth down or whatever, and um, and just go into hospice care. And so those conversations are now starting to come along, but there's still this place between palliative and hospice care where, especially like in cancer patients, and it could even be in, cardiovascular patients and respiratory patients, that the doctors have to also kind of come to terms with the fact that, yeah, let's allow this person to have quality now until the end of their life, instead of pushing and pushing and pushing for quantity. And I think that kind of the two big points that nurses need to keep in mind when talking with family is quality and quantity. And families are going to be at different times are going to want one or the other. So, at first, families might really, really want quantity because they're like, okay, well, we weren't ready for this, and we want a lot more time, and so they might want quantity. And I think that that's why a lot of that cancer treatments go into place, even when the trajectory, because of the advanced cancer, isn't really good, but people want to really try for that quantity. And then um, they families kind of come to the understanding that they're getting quantity, but they're not getting quality. So their loved one is in a lot of pain, isn't really able to maybe respond or be involved or get out of bed or care for themselves, or the quality of life that that patient that loved one once had is totally gone. So they might be getting days, extra days, but they're painful days to experience for both the family member and the loved one. So these are, again, quantity, quality are words that we need to be using with family when we are talking to them about their trajectory and their prognosis and their end of life plans. I am going to give a little note here that I am recording this at home, and I have a sleeping dog on the couch who starts to snore very loudly, so I'm trying to keep him quiet. So if you hear something, that is what that is, and that was it. Okay, so moving on. Okay, so okay, so I think I've already mentioned this, but to be considered in hospice care, all treatments should be seen as curative, or all treatments that can be seen as curative must stop. And so if they're defined, I mean, I think that when we look at when I say seen as, that's even like if insurance sees them as curative, they have to be stopped. And so this is where there's still this progression and this fight in palliative care, for people to be able to get certain treatments that are not curative but are comfort. Okay, so this comes from the old curriculum, and I really liked this particular slide, so I slid this in here. But just some myths and facts regarding hospice. And it says Medicare provides only 6 months of hospice care, and this is, again, part of our paradigm shift. So this is hopefully moving, and in some situations it does. And so that's why they had placed it under the myth. Hospital care, our hospice care is different from state to state and facility to facility. You can go back, you can go on to hospice care, and then you can go off of hospice care. So you don't have to stay on it if you decide you want to go back to curative treatments. Hospice does not mean giving up hope. And hospice doesn't help people die, it provides them support in the process of dying. Hospice is more than just pain medication. Hospice is a holistic environment that looks at the client and their family physically, emotionally, spiritually, and does a really good job of supporting the entire family and even close friends to the family. Let's see. All right. So here's some more myths and facts. You generally have a primary care provider who refers you, um, and any primary care provider can refer you. Hospice is for clients an end of life. It doesn't matter what the diagnosis is. Hospice supports the entire family during the illness and for 1 year after. Well, and some hospices will continue to support the family forever, um, with counseling and things like that, as long as it can be related to um, as long as it can be related to the um, the loss. So, like if it's grieving, if it's grief, counseling related to that loss, that they will continue to do it for as long as the family needs. Need to pause here for a second. Okay, so we are back on here. Let me get this back up. All right, so when we start to look at physical assessment, so this is the client who's in the dying process. Um, so in their last days to hours of life. So if you look at these and you should be able to start pulling up some of that knowledge, applying some of that knowledge from shock. So some of these are directly related to the shock cycle that the client is in. Most of these signs and symptoms are not distressing to the client. It's the body's way of shutting down. So forcing fluids and food at this time can make it very painful for the client because their body is shutting down, and doesn't need all of those things anymore. There's that congestion and gurgling. This is often called the death rattle. And with the Cheyne-Stokes breathing, and there's going to be times um, of apnea in there, that if there's the families are around the patient and they're waiting, with every breath, and waiting for the next breath to come, that can become very distressing for clients, and not so much for clients, for family members. So making sure that family is aware of what that is, and that's the body and the brain slowing down, and the acid-base balance, that causes the slowing of the breathing and the apnea. And then again, when the breathing may stop, and then the heart will still beat. And so if the person is young and their heart is very strong, they may have longer apnea periods, and then take a deep breath again, because the heart is still working well and strong. So these are things to prepare the family for. Okay, there can be restlessness. We check to see if that's from pain. If not, it could just be part of the restlessness. We'll talk about that a little bit later. And sometimes they can medicate clients for it, and sometimes not. We'll talk about that later. Psychosocial assessment. So you've been going through this with your frontal gifts. So a lot of this kind of should come together for you as you're reading through this. And just remember that we are, we're there to listen. We don't have to believe what they say. We don't have to understand what they're saying. We don't have to justify what they're saying. But we just have to be with the patient and the family to provide as much support as possible, to let them know what, to the best of our knowledge, what is going on, and what the trajectory is, and what the process is, and um, just really, be there and be ready and willing to listen to um, what they're saying, and ask questions on what they need and what you can help them with. So again, people want a good death, um, but they don't always know what that means, and we are there to guide the process, give support, and provide care. So this also comes from the old curriculum, and it was a slide that I liked. A dying person's Bill of Rights, and so these are just reminders for us. Um, it's easy when we have um, been in our profession for a while, and as a way to protect ourselves emotionally, to kind of wall ourselves off to the fact that this person um, is a human being, um, and is going through this the first time, and uh, their only time, because you only die once, and even though we have maybe been through this with people many times, we need to just sort of keep this in mind every time. Um, Treat them as a human being. Talk to them even when they're not conscious. Tell them what you're doing. Tell them who's in the room. Um, if they maintain a sense of hopefulness, that's fine. There's no reason for you to tell them that there's no reason to be hopeful. Even when you know the trajectory, and even when you've explained the trajectory, um, allow them to still be hopeful. And um, that is one thing, and we'll mention it again later, is that hope actually keeps people going for a really long time, and improves their quality of life, to have hope. And hope may mean, for some people, hope may mean cure, but for other people, hope is just that there's something else beyond this. And so allow people to have hope. Um, um, Allow people to express whatever emotions that they have about death, and in their own way. So um, don't judge how people respond to this process. Um, and make sure that their needs are being met, that their decisions are being followed. Um, we will provide them um, care at all times, that we don't walk away. A DNR does not mean that we leave them by the side of the road. We stay with them. We keep them free from pain. We answer questions honestly. Um, we have no right to deceive anyone. And then again, there's some ethical things that come into that when you're asked by family members to not be truthful. And so those are ethical questions that come up to ethical boards, um, and that you do your best to inform the family on what your ethical what your code of ethics expects of you. Um, so again, we want their family members to be there with them. We need to do our best to help their family members accept the dying process. They want to die in peace with dignity. Um, they want to still be an individual. They don't want to be judged. Um, they want to be cared for by people who are sensitive and knowledgeable, and want to help them, and want to make these last decisions of their life meaningful to them. Pain management. So, pain is the most distressing to both the patient and family and should be treated no matter what. And so people, um, that's people's biggest fear in dying, is that dying is going to be painful. And so it's often asked up front, is this going to hurt? And is this going to be painful? And so it is a huge part of our role to make sure that we do everything we can to um, treat pain at any level. Um, and no matter what, we treat them at any level. And so I know that there's conversation and there's fear that the pain meds that we might be giving them could lead to death or could hasten their death. This is not a form of euthanasia, and you're backed up by the ANA with this, and we'll talk about this later when we get to treatments later on. But to know that when we are following standard protocol for pain treatment, um, that it is more important to provide pain management than it is to slow the death process down. And there's also, lots of complementary and alternative therapies that are becoming more popular now. Um, and massage can help with decreasing pain and providing relaxation. You just want to make sure that the massage therapist is aware of tissue damage and staying away from some of those tissue areas. Music therapy can provide pain relief and relaxation. Therapeutic touch, like um, Rinki, I can't really say that, therapy done by a professional provider can help a lot with pain management. And then aromatherapy can decrease pain and anxiety. Some aromas that are used are lavender and chamomile, rose, ginger, rosemary, lemongrass, and sage. Weakness management. So people naturally stop eating and drinking, and some of this is they just become weak and unable to swallow, and so that's sort of this natural process. So they can't they can't swallow very well. They've become weak. Their body doesn't need food and fluid. It's not asking for it, it's not craving it anymore. The digestive process is stopping. Um, Kidneys are slowing down and stopping. Um, so part of this sort of is part of the process. And I know that there was a link of reading for you to do from the Bellingham Herald that's kind of related to this stopping eating in the process to um, kind of get the death process started. And so bringing this back around is that making sure that that family members understand that um, just because they've become weak and they cannot swallow now, doesn't mean that we need to do an intervention to make sure that they get food in them or fluid in them. It's part of this process. It's the body telling us that it's time for us to stop doing those things. So what can we do is we provide comfort. We make sure that they have mouth care. We make sure that their lips are staying moist. Um, and we give medications in an alternative route, whatever is the least invasive route that we can do. So dyspnea management. And so dyspnea is considered by patients, family members, and healthcare providers as a major cause of suffering at end of life. Um, and it has also been described as terrifying. And so these are things that we need to be aware of. And there's some non-pharmacological treatments and pharmacological treatments, but some of the things that we might be able to do early on is we can position patients, we can give them some cool air, we can give them some cold cloths to their face that might make them feel like a little more refreshed. We make sure that they have rest periods. we can encourage imagery and deep breathing, and um, continually to use and to practice imagery and deep breathing um, continues to show that if people are comfortable with it and continue to do it, that it becomes more and more powerful for them. So um, don't hesitate to try to walk somebody down a path with imagery and deep breathing to help them in these processes. And so then pharmacological. So we're going to treat primary causes to relieve the uh, psychological distress that accompanies the symptoms. So um, opioids, as such as morphine, are the sort of the standard treatment at end of life, and it decreases the anxiety and the air hunger, so the client doesn't feel the need to pull to breathe. It slows down the desire, that the respiratory desire. Um, and anticholinergics help dry up the secretions that help with the death rattle. Bronchodilators and corticosteroids are going to help with breathing. Um, sedatives, again, they can decrease that anxiety and restlessness. That can help with breathing. Oxygen is not a standard for all end-of-life patients, but if it is given, give it by nasal cannula, not by mask. Masks can be frightening if you're already kind of feeling like you're having a hard time breathing. Diuretics are given for those fluid overload that might be making it difficult for the lung expansion. And, antibiotics for infection that are causing pain or breathing difficulty. So then there can also be some nausea and vomiting at end of life, and this is usually with the client that have AIDS or breast, stomach, or gynecological cancers. And so there's a lot of antiemetic agents there that should be familiar to you that can be given in many different ways. But as part of our role is to remove any source of odor, get something good smelling in there, make sure that the room temperature is comfortable to them. Does it need to be warmer? Does it need to be cooler to help with that nausea and vomiting? And aromatherapy can also be helpful in this too. It just depends on if you can find the right aroma that helps the person not feel quite so nauseated. So restlessness and delirium management. So one of the things to think about with restlessness is that it's not unusual for clients at the end of life, and they might have even be in a place where they have what some people kind of call they've somewhat sort of checked out, and so they're not responsive to everybody else in the room, and they might start to sort of pick at themselves. So just index finger and thumb, they might pick at their abdomen, or at their bedding, at their leg, just their gown, whatever, just kind of pick at it. They're not causing themselves harm. And sometimes if it's not distressing the patient or the family, it's just sort of restlessness, then it's not treated at all. And sometimes for family, they'll be asked, we can give your loved one something that'll keep them from picking at themselves like that. But they also will become quite sedated and not very responsive. And so family can decide, if they're not hurting themselves, and you still want to be able to have those brief interactions with them where they might be able to share something like what you guys are learning in Final Gifts. Those are kind of the opportunity to have those conversations, that when you sedate somebody just to keep them from picking, you also might lose some opportunities to be able to communicate between the loved one. Let's see. I can't think of anything else. So yeah, at first if you have a client that becomes restless, so at first you just want to make sure that there isn't something else going on, pain or that their catheter's become clogged or they're constipated or anything like that. And then outside of that, decide if you're going to treat it as a delirium, um, or if you're going to use some alternative therapies, or if you're going to kind of just let them be as long as they're not hurting themselves. So here are some other things that kind of brings us again back to some of the videos that we watch, um, the readings that you've had, the final gifts, kind of touch on all of these things. And um, so one is, I've kind of talked about this as death is the termination of life, but dying is a process. And people move through the process with lots of different behaviors. And so just sort of being aware of behaviors that family members and that the client themselves will have during this death process, and not judging any of those behaviors and just letting them be because that's who they are in that moment. Final gifts and other readings kind of talk on this. Remember that spirituality isn't always connected to religion. And you don't have to be the same religion as the client to be able to listen. And you can always suggest having someone come and talk to them if you're not comfortable. Out of religion and spirituality, often hope hangs in that. And hope can have a big effect on trajectory. And so that's something to, again, when we're talking about hope, people being able to have hope, and encouraging people's hope, not giving them false hope, but allowing them to live within their hope. So, and again, remembering that some of that can fall into the denial, in that grief process, and so continually reminding yourself that you are not in that person's shoes, and so it's difficult for you to have a judgment on how they respond to that situation. So always keep that in mind. So seizures are not common at end of life. They're seen with specific illnesses like AIDS and brain tumors, or people who have a history of a seizure disorder. As far as refractory symptoms of distress, um, and when we're talking about palliative sedation, let's see. So there is no evidence that admission of medications for symptoms of distress using protocols hastens death, and that's what I was talking about. So if we're using the correct protocols, and we are providing the medication to decrease stress or distress of the dying process, um, um, it is we do not have to be concerned about whether it hastens death. And in all cases, ANA will back you up with that. So the Code of Ethics backs us up on that. The intent of palliative sedation is to promote comfort and not hasten death. This is what distinguishes it from euthanasia. So those are kind of things that, again, people really struggle with providing medications that will sedate a client who's already, close to respiratory failure because they're worried about hastening the death. And that is not something that we need to consider and worry about if we are following correct protocols. This is a slide that just talks about it's an example of a medicine wheel, and it's just again some background culture information, where there might be words or phrases that you hear that make you go, oh yeah, now I understand. Now I understand. Certain times clients want to be faced a certain direction towards the end of their life. They want their spirit to be able to leave their body and go a certain direction. And so it's important to be aware of, to get involved in, to ask questions when you are taking care of a client who comes from a culture that you are not familiar with and that is maybe different from your own. And so it's important for us to be asking questions on what can we do, what kind of needs do they have that are related to their culture and to the end of life process or the dying process in their culture. So postmortem care. So we've walked with the family through this process, and the family member has died. And it's very important to wait several minutes after that last breath to be sure that it is an apnea. And then listen to the heart with a stethoscope for a full minute to be sure that the heart has stopped. Before you pronounce death, you want to be very, very sure, because the family will have a surge of grief there, and it would be very difficult for them to have that and then the patient do the again from the chain strokes breathing. So don't rush to pronounce that. Let's see. When death is expected, so in a lot of these trajectories, when death is expected, an autopsy is not performed. We need to make sure that the family has had all the time that they want and need with their loved one, and making sure that everyone who needs to come and see them, who's able to come and see them, has come to see them, and that the family has had plenty of time, that the family has been involved in whatever way they want to be involved in with the postmortem care. If they want to be involved in washing the client, taking off jewelry, or any of those things, make sure that the family is involved in every way that they feel comfortable being involved in. When the family is with the client, with their loved one, alone, and again, you can give them as much time as they want. In that time, you are finishing up the paperwork and making the phone calls for the transfer of the body, and depending upon how your facility is set up, they'll either go to the morgue or the funeral home will come and take them directly, from the room. So it depends on how your system is set up. But part of our role is to get that ball rolling, so that happens, so that as soon as the family is done, the funeral home can come in, and the body isn't kind of just sort of left in limbo. It makes the family feel very comforted and supported to know that they know what the next step is, and even when they are there, so oftentimes, and maybe even in like a hospice house, family will even be present when the body is taken from the facility. So again, those are all things that help the family. So euthanasia and ethics in the end of life. So withdrawal or withholding of life-sustaining therapy, that used to be called passive euthanasia. And basically this is now letting the person die naturally. It does not cause death, but without it, whatever treatment that you're doing, whatever it is that you are doing, the therapy you're doing, with it there, the patient cannot die naturally. So by removing it, gives the client the ability to die naturally. This includes ventilation, IV fluids, and antibiotics. And and I know that I can see, in your brains as you're thinking, well, if somebody's ventilated and you take it off and they die, how is that you didn't kill them? But the thing is that if it had never been put on, they would have died naturally. And so by taking it away, they will die naturally. So then there's active euthanasia, but there's also kind of in the middle of that, there's assisted suicide. So, or assisted euthanasia. So, assisted um, is that the patient is given a like a prescription, and they can give themselves a dosage at the appointed time, whenever they have decided um, to end their life, and that is legal in Oregon, Washington, Vermont, and New Mexico. Um, and then there's also an active um, euthanasia, which is that the patient is not giving themselves the medication, but somebody else is. And um, there's obviously legal things involved in all of that, but ANA is very distinct on this, that nurses should not be involved in in um, these situations. So if a patient has a prescription to give themselves, or have their family member give them this medication so that ends their life, as nurses, we cannot give them that medication. We and I think that there's quite a bit of even a gray area of being present at the time that that occurs. And I think there's probably some gray area in that of still providing comfort care when this is taking place. So these are all things that will still be coming down and coming around, but just wanted you to be aware of that ANA does not support nurses being involved in assisted suicide um, or um, active euthanasia. Okay, so now we're going to talk a little bit about end of life in children. And so I pulled these slides because I liked them from last year's information. Let's see. Okay. So okay. This I'm gonna write on this one this time. This is an important concept right here. Okay, when we're talking about end of life for children, it is part of our advocacy role and our ethical role to be considering what is in the best interest of the child and not necessarily the parents. And as you can imagine, there's a weird ethical situation there because um, because the client is not the client is a minor. The parents make the decisions. Parents make all the medical decisions. It's our opportunity to walk parents through what is best for the child and to not give quantity without quality. Okay. There was an IOM study that children who die fail to receive competent and compassionate care that meets their physical, emotional, and spiritual needs. And a lot of it is because providers and parents are not comfortable with going to the fact that this is a child that's dying and making sure that their needs are met at that level. Helping parents to let go, and then getting kids who are on a chronic disease trajectory um, into palliative care early. So like kids that have like cystic fibrosis and things like that. This is a nice chart that just talks about children's understanding of death and the possible behavioral responses. So I'm just going to let you guys read through that. And here's just a continuation of that one. Okay, so barriers to palliative care for children. There's few hospice programs and palliative care programs that are specialized for children. At the end of this PowerPoint, there's a website link to some information related to this if you're interested. Hospice can be highly based on insurance, and some companies only allow a few days in hospice or hospice house. We kind of talked about that, how there's some myths in that, there's some fact in that, and those are changing. But a lot of those hospice houses are not necessarily set up for the need of a child. Um, and so again, this is a progress that's changing. So hopefully in the future we will start to see more palliative care teams for children and hospice care teams for children. Let's see. So there's this also big for barriers is unrealistic parent expectations, differences in understanding of the child's prognosis between the doctor and the parent, lack of parents' readiness to have this discussion. So be aware of all of those things when you're working with parents and in a child that's end of life or in need of palliative care. Um, this appropriate early in course um, of the disease to get kids on that palliative care, making sure that we're meeting the child's physical, psychological, and spiritual needs, and that's a lot of that is also their developmental needs. Making sure their parents are getting some relief, and making sure that we're enhancing the quality of life and not just giving quantity of life. So considerations for adolescents. They often are called uniquely old souls. They at a very young age they have to come to terms with the end of their life. They are mature enough developmentally to know what that means. So more so than say a school age child, and facing that a lot sooner than their peers, coming to terms with the fact that your life ends and it ends completely. And so that they're often considered kind of old souls from that. So a really good book, many of you probably have read it or have heard of it. It kind of talks about adolescents who are in this um, process in their life. Is a book by John Green called Fault in Our Stars. It kind of looks at how kids look at this process or how teenagers look at this process. But it's a novel. It's an easy read. Teens should be allowed to make their own decisions about plan of care, but should be educated on all details so that they're able to make an educated decision. Parents are more often able to accept a teen's decision if they know that it's an educated one. So we speak to them clearly and honestly like we do adults. We work with their developmental level to give them the amount of information that we can to help them make decisions. And we work with their parents to help them allow their child to make their own decisions. And again, it's a quality of life conversation where sometimes for parents it's a quantity of life conversation. So kind of be aware of that. All right. Again, some strategies for communicating with a dying child. Ethical issues. So you can imagine when we have ethical issues with adults and their family members, the ethical issues that we're going to have with children and their family members is very is fraught with lots of emotion. So withdrawing treatment. So when do we decide that it's time to let go? And all of the process that it would take a parent to come to those terms. And how do you decide not to do a new study? So withholding new treatment. How do you decide when enough is enough? And you might say it's one thing for you to decide for yourself. How do you decide that for your child? And then there's also there's a whole other side of it when there's parental refusal of treatment for a child, where it's something that could cause or could provide a lot of comfort, or who could improve quality of life. So there's ethical issues on both sides of this. And then again with DNR orders, understanding what those look like, what that means, what dying a natural death looks like, what what removal of a ventilator would look like, all of those things to help the parents make those decisions and help, say, the adolescent make those decisions. And here's the review of our concepts. So you can take some time to go through those, and I should have touched on all of that. I think the one thing that I didn't necessarily talk a lot about was providing psychosocial support to family or other caregivers, so mostly like the other caregivers. And so realizing that that the same kind of support that you may need to give to family members who become very distressed, you can also have colleagues who become very distressed. Certain deaths might be more stressful for them than others. So being aware of your role in listening and and um, not having all the answers, but being someone who can listen and who can provide comfort. Here's those resources that I was talking about.